Welcome to HEAL 6825 Quality and Safety in Healthcare. I'm Dr. Rapala and I am your professor for this class. And each week I'll present a small, short presentation on the PowerPoint deck you'll find in your materials, just to pull out a couple concepts that may not be evident as you read the slides. And I won't go over every slide, but mainly some key concepts that may not translate as well into just reading them. So with that, we'll get started with our first week. And I want to just start with three definitions to keep in mind here. One is patient safety. And what is safety? Patient safety in particular, freedom from accidental or preventable injuries produced by medical care. You can have non-preventable injuries as well, and we'll talk about that later. Quality is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So, do we have the best quality evidence, and are we using that in our populations and individuals? And finally, quality improvement is how you fix the things you see that are wrong and promote good health care. And during and after this course, you may think, gosh, this is kind of a gloomy area. We're talking about errors. We're talking about patients that aren't getting the care that they need. But actually, it can be a really rewarding area, and you can use these concepts whether you're practicing in a community clinic. You can look for issues to correct and lead your teammates, or even as an individual to improve the care you provide, or as a part of a larger hospital system. There's always some quality things going on, and the frontline and leadership aspects are very important. So this really is an important area as you go on in your career. So I'd like you to visualize what quality is, and I think the best representation is this number 3, and this is a recent slide from the Institute for Healthcare Improvement. Basically, quality has these 6 aspects: safety, effectiveness. Is the care effective? Is it on time? Is it equitable? Is it efficient? We know healthcare often isn't efficient. And is it patient-centered? Triple aim is also a concept that was developed to look at care within the community. So how can we deliver better care, better health, resulting health at a lower cost? Health equity, which you saw in the previous slide, is actually something that we're looking at in particular now, nationally and internationally, even before COVID-19. And it hasn't gotten a lot of attention. And basically what it says is health differences that are unnecessary and avoidable, as well as unfair and unjust. And so in our COVID-19 experience, we know that there is some health equity issues. Maybe it's lack of the internet in the inner city or rural areas, that patients can't access their healthcare information or make appointments. It can also be crowded living conditions, all kinds of different things, but things that actually are preventable. Health disparities are a larger group, and those are differences in healthcare outcomes, whether unjust or not. So there can be other reasons that may or may not be preventable. But this is an area we're looking at, and you actually have a reading coming up to look at health equity issues. So one concept that I want to just share is the difference between quality and safety. And this is just a useful tool that I kind of keep a mental model of. And basically it says a safety issue has high causality and high immediacy. So it's usually something that's pretty clear is caused by a particular act, medication error or leaving a sponge in somebody. And the high immediacy, you can tell right away. Quality issues, on the other hand, have a little more difficult causality to prove, and maybe a little less immediacy. So here's a couple examples. So If you give intrathecal vincristine by mistake or potassium chloride, the causality is high, you know that caused the death, and it's immediate. So if you go back to this slide, you can see it's clearly in the A area. Other things like failure to vaccinate really have a high causality, but typically, unless there's some sort of epidemic of some sort or a wave of disease, it may not be an immediate cause. So you'll see flare-ups of whooping cough and things like that. And you know, it may be because there's failure to vaccinate, although maybe the vaccine wore off too. So there's all sorts of different issues. Failure to use thrombolytics in an MI. The causality may be low because there might be lots and lots of different factors, but maybe it did cause the death right away. So that would be looking at the high immediacy and low causality, so it's difficult to trace. Whereas beta blockers after a MI, maybe low causality and a lower immediacy. It could happen over time. So the thing to keep in mind with this is it always helps me kind of figure out what is a safety issue. Sometimes experts differ in how they place safety and quality issues. So you may see an expert group say this is a patient safety issue, or you may say an expert say this is a quality issue. So sometimes the different groups place them maybe a little differently than you would have done this model. The other thing is time sometimes changes these things. So for example, with our recent pandemic, hand washing, we know was a high linkage to COVID-19 and fairly immediate. So that really put it front and center in the patient safety. Hand washing at other times may have been a little lower causality and immediacy. So it just depends on the context as well. So who defines quality? In days past, senior clinicians, usually physicians, did. And the care often varied. So you might have somebody who managed cardiovascular surgery patients differently in an academic medical center than a small community center. Now we use research mostly to drive best practices, and best practice is what establishes the standard of care. So I think you've seen this pyramid before, where evidence really drives improvement. Although sometimes in quality and safety initiatives, it's a younger area, so you may not see as many peer-reviewed studies. So organizations that look at the evidence and make recommendations are WHO, CDC, the National Institute of Health, the National Academy of Health, which used to be the Institute of Medicine, IHI, and AHRQ. The one thing to look at when you're looking at, well, many things to look at. So maybe there is a process in care that you want to put into practice. And so you want to see that there's strong evidence. So for example, back to hand washing, we know there's strong evidence that leads to improved outcomes. It accurately captures whether the evidence-based practice works. It can address a process that has few intervening care processes that must occur. This is important. We'll talk about this more in implementation science, but if you have a care issue that has a lot of different things attached to it, maybe it's hard to learn, maybe there's multiple intervening factors, like maybe you want to put something in the electronic health record, but the particular organization has many different EHR sources. It could be hard. That's something to consider. And you want to implement a measure that doesn't have any unintended consequences, which sometimes is hard to predict. So regulators and payers have weighed in, and of course, they have pushed some best practices, and help focus some measures as well. And this is just a visual I like to use, and actually it's a little bit dated. It's from 2007. But it shows in patient safety, and it could be quality, all the different groups that weigh in on safety. And the healthcare system has to figure out, okay, how do I prioritize? What must I do? And all of those other things. So when you look at implementation, some things work, and this is from AHRQ, and it's a measure that they track, and it shows hospital patients with an anticoagulant related adverse event due to low molecular weight heparin, and those events actually have gone down over time, and it's probably based on Medicare data. So that looks like the interventions used there are working. Some don't. The Joint Commission, which is a accreditation agency, really pushed pain standards in 2000 and made freedom from pain a patient right. It didn't completely produce the opioid epidemic, but it did create a measure that hospitals in particular had to address. So it caused caregivers and providers to probably prescribe some unnecessary opioids. Now, did it create the whole crisis? No, but it probably helped. So one of the things we're going to look, and this is actually a recent book called Still Not Safe, in the years after the Institute of Medicine report. So what we're going to look at in this class in particular is how can we improve healthcare? How can we function in a flawed system? And really importantly, how do we support ourselves and others, including other caregivers and patients as well? So I hope you all have a good week. Let me know if you have any questions about the course, and I will see you at the next lecture.